function is to is to scan your body for tension. And where you find tension, I want you to intentionally contract those muscles, and on the out breath, intentionally release it. So it might look something like this. Yeah. If you want to stretch, if you want to crack, anything that you can do in the next, say, 30 seconds to get nice and relaxed. Only 30 seconds though, because I don't want you to go to sleep. Okay. We all good? Let's give it a shot. All right, welcome back. Hopefully everyone was able to take what they need there for a moment, and we can hop into learning now. Okay. All right. So a little background about the ACEs study. What's interesting is it's older now. We're in the year 2025, so this is over 25 years old at this point. The original study, I think what a lot of people don't realize about the ACEs study, we think about this in a lot of times in terms of like mental health and social services, but this was a medical study. It actually was an obesity study at its start. And so I think that's kind of important for people to remember. This did start in 1997. We really didn't start talking about it until about 2015, so about 10 years ago or so. And it was done here in San Diego at Kaiser. Dr. Fleddy and Dr. Onda was the cardiologist. A whole team of people came together. But essentially, Dr. Fleddy was tasked with addressing the obesity epidemic. And so think about, we're going to get into demographics here, but this is San Diego, Kaiser Insurance, which is typically a private insurance. It's rather costly. So you can think about the types of people that are going to have access to this study at the beginning, right? Essentially, the long story short is what they found was a statistically significant correlation between health disparities, ultimately leading to early death, and childhood trauma or adversity. And so we'll kind of break that down, but that was the big overarching finding, right? So essentially what happened was they had an obesity clinic. They brought people in, they gave people meal plans and access to a nutritionist and exercise and everything you would need, to be successful at losing fat, gaining muscle, improving obesity. What they found was some people were able to do that. They just needed the education, the tools, and they were able to do that. Other people did very well, but then came back having gained more weight. Then you had some people who followed the plan and still didn't lose weight, right? Or had other health disparities that didn't make a lot of sense. And so some of the information that was coming back was not really making sense to them from a medical perspective. Even people who lost the weight and were exercising and were eating well, then, show up having a stroke or show up having heart disease. People who have never smoked showing up with, signs of COPD or lung disease. And so what they started to do was they started to talk to people, which was the most powerful thing any medical doctor has ever done, right? They started to talk to people, and what they started to realize was individuals who expressed having different experiences in their childhood had a kind of predisposition to certain health disparities. So they wanted to get more information on this, get more specific on this. And so they started with a survey. This was a self-reported 10-question survey that I'm going to show you that asked about different types of trauma in childhood. So they asked about prior to the age of 18. Now, we know that the brain stops developing more around the age of 25, 26, but there's more development after the age of 18 that would lead to less impact. So that's why they kept it 18 or younger, because they're really looking for severe negative impacts to health, which is going to be on the developing brains and bodies of children. Okay? So the types of trauma they asked about: individual, household, and family-based, which I'm going to explain. One thing that I do want to point out, and why we go deeper now, why we're going to have so many conversations about the next steps, is because the ACEs study was a great jumping off point. It was great information. It still is great information. And we know now, so many years later, we are aware of so many types of trauma and adversity in childhood that are not included in the ACEs questionnaire. We also understand that between the ages of 18 and any age, trauma can occur, right? And so there's a lot more information that's out now that we've expanded on this. And so some of the things that are not included here that you may be working with a lot of families experiencing these types of adversity are things like community-based trauma in terms of living in a food desert, right? So I was born in a desert, quite literally, where there was no access to organic foods. There was no access to fresh foods. It's like a lot of bars in my hometown and a lot of fast food restaurants. Like, so that's considered a food desert, which means my community is more prone to poverty and more prone to health disparities based on the access of food that we have or lack of access, right? Community violence. If you grow up in a neighborhood that is surrounded by a lot of violence and a lot of a high crime rate, things like this, that can create traumatic experiences. Systems trauma. These are going to be things like, for example, depending on how you learn, the school system can be traumatic, right? Depending on what kind of student you are. If you're neurodivergent, the school system can be incredibly adverse or traumatic for you. And so that's something that's not included there. Other systems trauma would include the justice system, the juvenile justice system, healthcare, right? If let's say you're undocumented and trying to access certain services and you can't because of your immigration status, that can be a system, something that systems trauma. If someone in your family was deported, that's going to be a systems-based trauma. So things like that. Societal-based trauma are going to be things like you have gender or sex-based disparities, discrimination, oppression, even I would say racism would fall into that. And that racism is going to fall into historical trauma as well. So in the US, we know that we have a long history that still plays out in our society today. And so historical traumas like sex-based discrimination as well as race-based discrimination. So these are all things that can happen to families and children that could be traumatic that are not necessarily included in the ACEs questionnaire. So the ACEs questionnaire only asks about very specific things. So I want to start with that to set the foundation for there's further that we're going to go with this, right? And just because you have a family or a client who doesn't have many ACEs doesn't mean they don't have adversity, if that makes sense. So we want to kind of broaden our scope on that. So here's the original ACEs questionnaire. I'm going to leave this up for a moment if anyone does want to go ahead and read the questionnaire and get their own score. I do think it's important that as providers, we all know our ACE score and we know what we're bringing into any situation or environment. It's an interesting thought to say, you know, leave your experiences at home or what have you, but we are human beings and we carry our experiences with us 100% of the time. So I think it's important that we have self-awareness and knowing what we might be sensitive to or what might trigger us in any given situation. And so knowing your ACE score can help you with that. That being said, this can activate a lot of hard, maybe memories or thoughts or emotions. And so my invitation is if you are going to get your ACE score for the first time today, to please, you know, take what you need, take a moment if you need, call your therapist after this if you need to and you have one, you know, reach out to your support systems and just make sure you take care of yourself. So I'm going to give you a moment to go over that. For each question, there's 10 questions. For each question, you're going to get a point if you answer yes. And at the end, you'll get a score out of 10. All right, so I do want to mention a couple of things just about this assessment at all. It is very specific with certain types of violence, but also if this assessment was made for adults. So the people that they were working with were older adults, and so they're asking looking back. Nowadays, what's happening is pediatricians are using this with families to talk about children as they are children right now. So some of the shifts that you might expect to see are going to be like with separation or divorce. Children don't understand legal divorce. And so that's going to not be a part of the issue. It doesn't matter if they were legally divorced. The question is, did you have a trusted adult there and then they were gone for whatever reason? Maybe they passed away unexpectedly. Maybe they were incarcerated. Maybe they were deported. There are all different types of reasons why a child might have a trusted adult present and then not. And that's really what is the root of what the assessment is asking for in questions like that. Okay. I did post something as well. So I just use myself as an example for all of these things. I have an ACE score of 9. And I think it's important. I also have a resiliency score of like 50 out of 52 or something like that, right? And I think it's very, very important that if we're going to talk about trauma or ACEs specifically, we also talk about resilience. So if you're going to assess someone for the hard things they've been through, we also want to assess them for the things that make them strong and resilient. And so there's 2 scales that I like to use for that. One is the HOPE scale, or personally, my favorite is the DARS, the Devereux Resiliency Scale. And so I put both of those in the chat just so everyone knows. I don't think we should ever have a conversation about ACEs or trauma without also talking about resilience, right? And so I think also I would mention, just because this is a pet peeve of mine as a survivor, when we're working with survivors, I think it's very important that we remember not to credit their experience with who they are, right? So a lot of times growing up, what I would hear is like, yeah, you've been through a lot, but like, look at you, you're so strong because of it. Oh, if you didn't have those experiences, you wouldn't be so strong. False. I could have been so much more potentially had I not experienced the abuses that I did. And so I don't want to ever credit, resilience, or I don't want to credit trauma with their sense of resilience. So just something I had to throw out there because I hear it a lot, right? Trauma survivors are strong anyway. The trauma just forces us to prove it, right? So we want to keep that in mind. So here's the original ACE score breakdown. They originally assessed 17,000 people. At this point, it's well over, I think, 400,000 people that have taken the ACEs and reported results. And so again, we're just going off of the original study here. At that time, about a third of the people that they surveyed had no ACEs, right? And only about 12% had 4 or more. Now, where they saw the health disparities, which we're going to go over, was at 4 or more. So yeah, having an ACE or 2 is not necessarily great, but they didn't see really any strong health impacts at 1, 2, or 3. Where they really saw a big jump in the health disparities was at an ACE score of 4 or more. So that's really where they focused a lot of their work. Now, I will say this, currently, these are not the numbers. It's actually, at this point in time, you are an outlier if you have 0 ACEs, which is, of course, something that we're all working very hard to address, right, and to change. But different statistics as of right now, okay? So the abuses that the original study asked about was physical, emotional, and sexual abuse. They asked about physical and emotional neglect. And then they asked about mental illness, incarcerated relative, mother treated violently specifically, not just domestic violence, but mother treated violently, substance abuse, and divorce or separation. So again, I'm going to keep pointing out certain things that have changed now, certain things like mental illness in the home, right? Well, having mental illness in the home in and of itself is not necessarily traumatic, right? Having undiagnosed, unmedicated, untreated, potentially violent mental illness could be, right? And so there's a lot of differences in the conversation around mental illness in the home, a lot of different conversations around domestic violence in the home. Again, this is very foundational. One of the things that they did release that was really, I thought, very insightful and interesting was around neglect. What they found was physical neglect happening at higher rates. However, emotional neglect being reported as more negatively impactful. So according to the people in this study that self-reported, having a parent who was physically present but not emotionally safe was more harmful than having a parent who was physically not there. Okay? We've seen a similar report in studies around domestic violence. We've heard, even from children saying that watching their mother be victimized is more painful and harmful than actually being the direct victim themselves. And so we've got some interesting information that comes out of these types of reports, right? Now, from there, they tracked what are some of the behaviors associated with these experiences, right? One is lack of physical activity. smoking, drinking, drug use, missed work. My mother is unfortunately a very clear statistic of ACEs. She had an ACE score of like 12, if I'm being honest, like so much stuff happened to that woman. And so, she was not very active. She smoked until the day she died. She never drank, but there was some drug use that occurred in her life as well. And so when we're looking at this continuum, then we see what happened. Well, she died of stomach cancer, which is a lifestyle related cancer. She also had COPD. So this makes sense for her, right? If we're just using my mom as a case study, it makes sense. She had a lot of very hard experiences, traumatic experiences as she was growing up and in her early 20s. She smoked, she got COPD, right? She didn't eat well, she didn't exercise, she didn't drink a lot of water. She got stomach cancer. Ultimately, this is why she passed away. So some cases make sense in that way, right? Some of the physical and mental health outcomes that they saw might make sense, like severe obesity, diabetes, depression, suicide attempts, STDs, STIs, heart disease, cancers, stroke, COPD, and broken bones. The question really that came out of this, though, was what about the, late 20s, early 30s, young person who eats well, who exercises, who drinks their water, who lives a really healthy lifestyle, who all of a sudden out of nowhere has a stroke? No markers, right? No signs, no warning signs. It just doesn't make sense for that person to have that medical experience. That's where they really started to dig into the impacts of ACEs. And so the continuum here, really originally, this is an expanded version, this is a more recent version, but originally it started here, right? And this was where we were having the conversations, right? You have adverse childhood experiences. This creates disrupted neurodevelopment, which all of this we're going to get really nerdy about in trauma responsive care. So when we start having those conversations, I'll explain all of this to you. We'll have examples and we'll get nerdy about it. So you have disrupted neurodevelopment, social, emotional, and cognitive impairment. Most individuals will have some variation of all three, but one may be more identifiable in their behavior. So adoption of health risk behavior. This could be, again, smoking, drinking, lack of activity, risky sexual behavior, what have you. This can lead to disease, disability, and social problems. One of the biggest social problems that we talk about is crime, right? Being involved in the justice system in some way. And then that can lead to early death. So in the experience of my mom, so with ACEs, they say that there is up to a 20-year difference life expectancy for those who have ACE scores of 4 or more. And so in the case of my mother, she passed away at 57 years old. So maybe about 20 years too young, right? If you think about that. And so it varies, of course, for every human being, but it is possible. So they're looking at this is the continuum that we're trying to disrupt. Now, adding on that are going to be the things that we talked about that were not included in the original ACEs questionnaire, which are going to be social conditions and local context. Growing up in a neighborhood where you're the only person of color, growing up in a neighborhood that has a lot of poverty, it has a lot of gang violence, like I said, food deserts, all these kinds of things. These are social conditions that might create adverse experiences. And then what I'm very interested in right now, and I think there are a lot of conversations around, is generational embodiment and historical trauma. So people who can be born with trauma in our blood and in our bodies before we even get to having these experiences ourselves, right? There's an amazing book that I think explains this well, which is called Post-Traumatic Slave Disorder. And so this is talking about how trauma is intergenerational, even outside of the experiences, right? It can be, it changes brains and bodies, it changes DNA, which then can carry on from mother to child. And so that's that generational embodiment and historical trauma coming out for individuals, even before they have experiences of their own. So this is kind of where the conversation is now. The ACEs study did not dive into all of that. So I'm trying to keep it like just on ACEs for you as much as I can. But it goes a lot deeper in the conversations we're having now. So, and again, we'll look at this more deeply in trauma responsive care as well. So the demographics of the ACEs study, right? This is so interesting because and I know I have human trafficking experts in here as well, right? And advocates in here as well. So when we first started talking about childhood trauma, it was treated in a very similar way as human trafficking, right? That doesn't happen here. That doesn't happen here. That's not our problem, right? The people in power, you know, the powers that be, like, oh no, that's only over there. That's only those people. I remember, and this is a throwback. I mean, I've been doing this now for like 17 years, so it must have been 15 years ago, you know. But I remember trying to do a presentation about ACEs and about trauma, and it was for a bunch of higher up, you know, representatives in the county. And at the time, the sheriff was there, and we had all these different agencies, and we were trying to have a conversation, say like, look, this is happening. It's happening in our families. We really need to get ahead of this. And we got about halfway through the training, the conversation, and they stopped us and they canceled it. And they said, we don't need to talk about this. Like, this is ridiculous. This is a waste of time. Like, the sheriff left. And so it, you know, it was like this thing where people were just not talking about. They weren't willing to hear any conversations about it. They weren't willing to face it. And the kind of thing they hid behind was, well, it doesn't happen to us. This doesn't matter to us. So the big thing that I think helped get ACEs some traction was the demographics. And so when we look at these demographics, very powerful that it was almost 50-50 male female. It was predominantly white, 75% white. It was very highly or higher ages, so 40 plus in age, and they were also highly educated. So this is going to be the demographics of people where they were able to say, look, this is not just in our communities of color. This is not just in poor communities. This is not just happening to the uneducated, you know, like this is everywhere, and it happens to everyone, and it's everyone's problem. And so I think these demographics are really what created that conversation or allowed that conversation to be had, because it really put into the faces of leaders, we can't ignore this anymore. You know, we can't, it does happen to everyone, everywhere, all the time. And so I think demographics are very important for this study. You also want to think about the socioeconomic status of the individuals who are being surveyed here, right? These 17,000 people, again, are on Kaiser insurance in San Diego. I have Kaiser in San Diego, and I'm telling you, it is expensive. And, you know, it is hard to get into. So, you know, these are people who are older, who are somewhat, you might imagine, are somewhat privileged, who are educated, who have money, and they're reporting ACEs happening to them. So it made it a little bit harder for governments and agencies to ignore, right? Sorry, but it's just the truth. It's just what happened, okay? So again, here's the breakdown by all of the different abuses. Again, so excuse me, I stand corrected. Emotional abuse. No, I'm right. I was right. Total physical abuse happening at higher rates, sexual abuse following, and then emotional abuse last. Let me recall this information. Oh, it's right in front of me. Males, males at higher rates of physical abuse, women or females at higher risk for emotional abuse, and sexual abuse, certainly. Okay. And then we see of the household challenges, as they call them, substance abuse, very, very high. I think any of us in this work might have guessed that. And then parental separation, also very high, and mental illness, very high. Okay. And then at neglect, we saw emotional neglect at higher rates than physical neglect. Okay. Again, here's the breakdown of the percentages. This is just literally from the ACE score, or from the ACE report that I wanted to show you. This is out of 17,337 people that were surveyed at this time. Okay. All right. So now I want to introduce you to Dr. Nadine Burke-Harris. I'm going to let her talk for a little bit. I'm going to type this into the chat. So Nadine Burke-Harris, if you're not familiar, she was California's first Surgeon General. She runs the Center for Youth Wellness up in the Northern California area. And she's now put out so many different resources at the Office of the Surgeon General for California. There's tons of videos and things you can watch, but this is her talking to at a TED Med, which is a TED Talk for medical professionals. I don't want you to lose sight of the fact that this started in the medical field. A lot of us here are mental health. A lot of us here are social service providers and things like that. And I think it can get lost sometimes how this started in medical and how it is still grounded in medical. Our medical professionals should be at the forefront of this, and can be, and they're the ones that are going to be catching this to potentially refer out to us, and then we can do our thing. But I think the narrative around ACEs and around childhood trauma has been kind of, again, shifted away from where it started and shifted into, oh, that's a mental health issue. That's a social service issue, instead of the holistic approach that this study really called for, right? This study was a huge evidence to how it is necessary for medical professionals, mental health professionals, and family service providers to all work together for the families to make sure they're getting what they need. Most of the symptoms of childhood trauma that may not be identifiable from a social perspective can be identified in a medical perspective. And so that's why it's so important that we remember where this started. So I want to go over and let Dr. Harris kind of spout at you for a minute. In our next conversation with deeper dive, we're going to lean on the work of Dr. Harris a little bit more than the study itself.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is Wonderful. If you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across a lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
All right, so a couple of things that we're going to hear more from Dr. Nadine Burke-Harris as we continue to move through this conversation. But a couple of things, like I said, I'll use myself as an example, right? Some of the things that I've been diagnosed with in my lifetime. As a child, I was diagnosed with heart problems. I had a heart monitor when I was 8 years old, probably like 6 to 8. I was on a heart monitor. I had heart surgery when I was 8 years old. They went in and did a bunch of testing because they thought I had a bad heart. Asthma I've been diagnosed with, eczema I've been diagnosed with. I was diagnosed epileptic as a teenager, hypoglycemic as well, speech impediment. None of these things are true to me now. So what was happening, let me tell you the truth of what it was, but back when I was young, we didn't have this information, we didn't have this education. I told you I have an ACE score of 9. I lived in a very chaotic home, and there was a lot of different things that were going on that were very traumatic. And so I didn't have heart problems. What was happening is I was having night terrors, and they put a heart monitor on me, but when it would go off was at night when I was sleeping. My heart would do crazy things. They didn't connect. They thought, well, something's wrong with her heart. They didn't connect the fact that I was actually having night terrors because of the trauma that I was experiencing. Similar with my asthma and my eczema, I wasn't, those aren't issues for me now. It was because I was in an unsafe situation. And so my immune system was severely negatively impacted. Similar with epilepsy, I wasn't having seizures. I was dissociating so strongly that it presented almost like a seizure. And so that's what they thought was going on. I wasn't hypoglycemic. We were poor and I didn't have enough to eat. So my blood sugar was very often far too low. I don't have a speech impediment. I'm a professional speaker now. And I think I speak okay. But when I was young, I did have a speech impediment because I was in a state of fear for most of my young life. The ADHD I'm probably going to hold on to because I think that's still accurate. But I have been told all my life I have impulse control issues, right? This is why I love to ride motorcycles and I love to jump out of planes and off of cliffs. And all of these things are non-issues for me. I love who I am. And I think these things can be superpowers, right? If we learn how to connect with them in positive ways. But my whole point to all of this was I have my, medical health file is insane. It's just massive. And none of those things are actually medically true. They're all trauma related. And so this information goes so far beyond the social and really truly requires, like Dr. Nadine Burke-Harris was saying, a start with our medical practitioners so that we can start addressing some of this stuff in early childhood. Right? I didn't start to get healthy until I was almost 30, when I started understanding all of this stuff. So imagine in my younger years, had I had this information and had my doctor and my therapist and all these people known about it, it could have been a different experience for me in my 20s, right? So adverse childhood experiences, this is smoking in adulthood. This is something I told you my mom smoked literally until the day she died, with oxygen on. And so very, very unsafe behavior, right? I smoked up until my late 20s. So very common with high ACEs. At this level, we see the ACE score of 6 or more actually being the highest rate. So there is a difference, a big difference between 4 and 6. But again, you just see it's a trend that it's going to go higher. The higher the ACEs, the higher the likelihood of smoking. This is going to be cigarettes, right? Or tobacco products. Now we have vapes and all of that. So then we have COPD, right? Higher the ACE score, higher the chances of the problem. And again, we see the big spike at 4 or more. So this one is huge. And this is one that gets talked about a lot, one of these outcomes, because this is self-reported underlining chronic depression. So chronic being a key word there. And also you're going to see a huge difference here between men and women. One of the conversations that comes out of this statistic specifically is it that much of a difference, or are men less likely to report, right? This is something with data and statistics. It's always a question that we have. Is there some other variable? Is there some other factor that might be contributing to the way that the numbers show up? And, in this case, I don't know. This is just what was reported in the study. So we do see that it goes up, depression goes up as the ACEs go up, but we see a huge difference between women, which is the red, and men, which is the yellow, right? Especially once we get to 4 or more. So it's actually a 60%, almost a 60% increase for women with 4 or more ACEs, that they're going to experience chronic depression, right? So that's a huge disparity right there. Suicidal attempts and ideation, going to go up to 20% at 4 or more. So a lot of trauma survivors attempting or ideating suicide. And again, you see it goes up by each ACE, but we see a huge jump between 2 and 3, and then another huge jump between 3 and 4. So those are going to be big markers there. So if we're knowing this, right, and the whole point to all of this, what Dr. Nadine Burke-Harris was saying is like, okay, if we can see this with families, if pediatricians can start screening for this when they have new clients come in, if they know that a child, like I attempted suicide at 12 years old, right? Had my pediatrician seen the symptoms or been able to screen for ACEs, they might have been able to get me some, assistance, some sort of support prior to me being 12 and prior to that attempt. So this is what we're talking about, the power of knowing this information, right? It's not a condemnation. It's an awareness that can help to get services to people before they even know they need it, right? So this one's going to be another interesting one that differentiates based on gender or sex. Risk of perpetuating domestic violence. So when we see females, right, who are in a home, grown up in a home of domestic violence, we do see that with females, they are at higher rates of becoming a victim of domestic violence themselves. And on the opposite end of the spectrum, we do see that males who become very, very at risk for perpetuating domestic violence. So they did measure both, and this is what it came out with. So for perpetuating, it goes up in all cases, except for between 3 and 4. They're just about the same, if not a little bit lower at 4. But then you get a huge jump at 5 ACEs, right? And then for men or males, it just goes up the entire time. Huge jump up from 3 to 4, and then huge jump up from 4 to 5. So again, they're really looking at this purple, right? They're really looking at this 4 or more as being the turning point for a lot of individuals in terms of the outcomes or the I guess, risk of some of these outcomes. Okay. Teen sexual behaviors, and I'm not showing you all the slides from the study. You're welcome to go read the entire study, but I just pulled out some that I think are going to be very applicable to the work that you do, right? So teen sexual behaviors, again, same trend. So you see the higher the ACEs, the higher the potential for outcome. We're looking at intercourse by 15. It's right there. That purple is 4 or more. So you see that big jump. Teen pregnancy at the purple, you see the big jump. Now we're getting almost up. We're up at 40% for teen pregnancy with an ACE score of 4 or more, right? Teen paternity, again, up, 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 up. We see the big jump at 4 or more, and you're at 35% there. So 1 in 3 teen guys, right, who have an ACE score of 4 or more are likely to experience teen paternity. Christina, that's a great question. So do ACE assessments vary depending on if it's given at a school versus other places? So it depends. I would say, yeah, it depends on who's giving the assessment. So I don't really suggest the ACEs assessment anymore. I'll go with the ACEs Q, which is by Dr. Nadine Burke-Harris and has been adapted for both pediatrics and mental health. So I would invite you, if you're a mental health professional looking to assess for ACEs, I would use the ACE Q. It's more advanced and it's done in a more protective way. The ACE study questionnaire was not meant to be a true assessment. It was meant to gather information for the study. So the ACE questionnaire was given to adults looking back at their childhood, not for children, right? Or not for families with children. So if you look at the ACEs Q, sorry, I'm like talking fast because I get excited. and as you noted, I'm a little ADHD. So, but the ACE Q, so I'm just going to jump ahead. We'll talk about this in the next one, but you asked. So now I'm just going to roll with it. Okay. I can't type and talk at the same time though, so give me a second. Okay, so in the back of The Deepest Well by Dr. Nadine Burke-Harris, you can also Google search this and you can find the ACE-Q by Dr. Harris. This is going to be an assessment meant to be used in pediatrics. And so if you were to use this in schools or something like that, okay, there you go. So like, yes, if you're working in schools, if you are in mental health and you are a licensed professional that's going to be doing these types of assessments, I would invite you to check out the ACE-Q. You will have to submit in order to gain access to the actual document, the assessment, you do have to submit your qualifications, and then they'll send you out a packet on how to conduct the assessment. But that's what the pediatrics are using as well. So I hope that answered your question. I think there's another question coming in.
I guess if it's medical, we'll cover it.
Okay, yeah, yeah. I was thinking, I don't know what's coming.
Yes.
That's a very good question, Susan. I'm not going to lie to you. I don't have the answer to that. That will have to go through whatever agency you're using. And I think, Zenaida, do you want to answer that?
I believe they do. At the hospital level, they are doing the test, and they do get it is covered actually. Now, whether it's covered by other insurance, I'm not sure, but for sure, medical, I believe they do.
Cool.
Yeah.
Lynn, yes. So you would go to, I don't have it at the ready right now, because I wasn't going to talk about this until part 2, but let's go. If you look up Dr. Nadine Burke-Harris, so the Center for Youth Wellness, Google that. You can go to, she has a couple different websites, and then you can access the ACE-Q there as well. Like I said, you will have to, I think you have to send them a message saying, hey, this is who I am. This is how I want to use it. Here's my license information. Yes, thank you for asking, Zoom user. It is inclusive in that it doesn't reference any, it is inclusive in that it doesn't ask necessarily about like gender orientation, anything like that. What it does ask about though, that is inclusive, that I really enjoy about the ACE-Q, is that it does ask about bullying due to race, ethnicity, gender, sexual orientation, all of those things. And that is considered an ACE for the ACE-Q. So yeah, definitely I would check it out. That's the best option that I know of at this time. Cool. And then we can talk, well, if Zoom, I don't know who you are, Zoom user, but if you want to talk inclusive language when doing an assessment, you hit me up because that's my jam. Right? I want to do all the trainings for all the professionals to have that language. Okay. Where am I at? Okay. So impaired work performance. So this is something that I'm so glad that they assessed and that we have conversations about, because this leads to so many other issues, right? This leads to food insecurity, to housing insecurity. This can lead to Potential avenues of being involved. Oh, hi, Steph. Nice to see you, or sort of have you on. Yeah, hit me up. You have my information. Steph, let's talk about it. So impaired worker performance, because if we're looking at, okay, we're dealing with potentially people who are experiencing poverty, right? Or they're experiencing unstable housing, or they're experiencing all these other things. The root cause could be impaired work performance. And one thing that people maybe don't think about enough is the difficulty in holding a job, in finding a job, holding a job. I think someone mentioned earlier having differently abled children. This is going to affect your ability to work as well. So in a very similar way that ACEs might. So you see very, very high rates of absenteeism among adults that have 4 or more ACEs. You see very high financial problems and high serious problems performing the job. So a lot of difficulties coming out of work performance, and also things like financial wellness. People who are brought up in homes that are very chaotic, or let's say they are experiencing poverty or something like this. Having financial training is not something that's very prevalent, right? Feeling healthy. So absenteeism, what I hope people understand about ACEs is it has physical manifestations. So when you have a child who's always in the health office because their tummy aches, that's real, and that's truly what they're experiencing, because the body cannot do all the things at once. And so if they're constantly in a stressed state, they're not able to digest properly. So fun fact, I'm also a personal trainer and nutrition coach. And the reason why I got into that was because I started to understand the connection between my relationship with my body and my healing of my trauma. And so if we can get people to really understand this connection, we are like one being, right? Then we can start to understand this. So when you have someone who's constantly sick or out sick, calling out sick, this could be mental health related. Sometimes anxiety prevents us from being able to do our job. Depression can prevent us from being able to go to work, but also, physical ailments, physical pains, chronic illnesses can be tied to ACEs in some cases. So things to keep in mind, right? And with serious financial problems, are they getting financial training? Are they getting financial literacy? Being able to have those skill sets to make sound financial choices. And then problems performing the job are going to be things like staying on task, right? There's a lot of overlapping of trauma survivorship and ADHD. And so that can make focusing and executing a job the way that somebody wants you to execute it a little bit more difficult for some people. So these are all just examples, right? This isn't the end all be all. I'm just giving examples of someone's experience that they might have, that if we're not looking deeper, we're going to miss what's really going on with individuals, right? So, and for trauma survivors, if you are a survivor yourself, like I am, I think it's important that we as survivors are very aware of this. We know where our vulnerabilities are, and that way we can, potentially work through them and or ask for what we need, get the supports and the resources that we need, and then be able to communicate that with employers and other individuals. So now looking into well-being here, this is going to be childhood experiences leading to later being raped. And this you're going to see, this goes up to almost 35% at 4 or more, but it is much higher. Even at 1 ACE, you double the chances, and then so on and so forth. You see this trend going higher and higher. Don't ask me why. There's all kinds of things that we can probably think about that would make people more vulnerable in this situation, but this study just said this is the people who were reporting it. And so you imagine if you already have 4 or more ACEs, that puts you more at risk for more trauma in all different types of ways, right? All right. So let me know if you have any questions. You can also email me. Let me put my email back in the chat here again. If you want to email me, I can send you the entire study or link to the entire study. If you'd like to look at all of those slides and the whole report, you're welcome to do that. I like to keep it kind of brief with the original ACEs because we're really looking at expanding on that now. But really what they're looking at, and this comes from CDC, right? Who was the second half. It was Kaiser and CDC who did the study at all. And so the CDC is looking to expand their work in restorative practices as well. And so they're looking at all these different branches that could be affected by ACEs, right? And one is going to be injury, like TBIs. traumatic brain injuries, fractures and burns. If you are in the mental health field, you know that TBIs can be incredibly dangerous, particularly when it comes to mental health outcomes. And so that's something for us to think about. If you know that you have a young child who has high ACEs, they're at risk for all of these things, at higher risk, right? And they're playing football, right? That's already going to be high risk for traumatic brain injury. That's a conversation that needs to be had with parents, right? They may be more vulnerable if they were severely neglected in their early childhood. Let's say you have a foster child who was adopted. They were severely neglected in their early months, right? Well, they may not have the skull density that they need to truly protect themselves from traumatic brain injury. So when that parent comes in, it might be a beneficial thing to let them know this so that maybe they don't want to let that child play football because it's just too dangerous for them, right? I talk to and I work with trauma survivors all the time from a fitness perspective, and it's a conversation of we have to take care of ourselves more so. We have to prioritize exercise and nutrition and proper hydration and all of these things a little bit more because of where we come from. And that's just part of it, right? Depression, anxiety, suicide, and PTSD are going to be all high on the mental health risk factors. And some of these things, again, you can think about. Some of them are going to be diagnosed, undiagnosed, medicated, not medicated. It's just something to put on radar, right? So the way that if you are a mental health professional, the way that you diagnose might change if you know you're working with a trauma survivor, right? Maternal health, unintended pregnancies are at higher rates. Pregnancy complications and also fetal death are at higher rates. So when you have someone, so for myself, if I were to go to try to carry a child, right, I have to understand that I'm behind the 8 ball for a lot of things. And I will say this, when you're working with trauma survivors, if you are a trauma survivor yourself, I think it's very important that we learn to advocate for ourselves in the medical field. I know I've had to fight with my doctors time and time again, like literally argue with my doctor until I got my way because I wanted screenings and they said I was too young. I was like, I want these blood tests done. I want these scans done. I want these screenings done. And they're like, you're too young to screen for cancer. You're too young to screen for, and I just argued until I got my way. I'm like, I'm not leaving here until I have all these screenings that I want, because I understand how my childhood experiences impact my body and my brain, but my doctor does not. So I just want to give that permission and that kind of guidance, and to, you have the right to be screened. So advocate for that. Especially if this is someone who is looking to reproduce, right? If you are a childbearing human, and that's going to be something that potentially adds complications just because of your childhood experience, and then whatever else might be on top of that, right? Infectious disease, HIV, STDs, STIs are going to be at higher rates. Of course, that's going to go up if you have risky sexual behavior, right? So behavior is a component, but it's not the only component to consider. Even when people don't have certain behaviors, they can still be at higher risk for these things, right? Chronic disease such as cancer and diabetes, with or without obesity, I will say that obesity is also higher risk for people with ACEs. And sometimes I've worked with a lot of individuals who it is a protection mechanism. So I've worked with female-bodied people who are trauma survivors, who are sexual assault survivors, who it feels very unsafe to lose the weight. So once they start getting healthier and they start losing the weight, they might start getting attention from people, and they might start getting, especially male-bodied people, saying, hey, you're looking good, and this kind of thing. And that makes them feel very at risk, and that makes them feel very scared. And so they will intentionally regain the weight as almost like a shield, as a protection. And so that's one thing that I've personally seen happen with a lot of my clients. And so I would include obesity in this chronic disease as well. Equally, there are people, like I said, who do everything right and still struggle with that. So risky behaviors like alcohol and drug abuse and unsafe sex, and then a lack of opportunities. So this happens, and I find that this can happen a lot due to behavior, right? So a lack of opportunity for education, occupation, and income. Particularly, I work with teens. They're my jam. I like teens the most out of any types of humans. Teens are my favorite. And one of the things that happens a lot with my survivor teens is that they have behaviors that maybe are very difficult in the classroom, or very difficult for adults around them to work with. And so they end up getting suspended or they get expelled, they get kicked out of school, and now they lose that access to education. They lose that. I know, me and you, Angel, let's go out to high schools and hang out. I know teens are not for everyone, but they are certainly for me. So what ends up happening though is that they have difficult behaviors, right? And I can tell you stories on stories about some things that I did in high school. And I am a good person. I know that I have a good heart and I am a good human, and I did some stupid stuff. Okay. Because I had no guidance and because I didn't know. I was a young person, right? The difference being, and I'll share more of this in trauma responsive care part 1 and part 2, but the difference being is that I had a lot of support and I had a lot of people who, when I did stupid things at school, they gave me a chance. Like I had teachers who would pull me aside and like hold me in their classroom and talk to me and counsel me, and instead of reporting me, right? Whereas my sisters, who also had some very difficult behaviors, they got expelled and sent to juvenile hall. And so they had very different outcomes later in life than I do. And that is because I was allowed to maintain access to my education, right? I was able to, I'm the only college graduate in my family. I'll be the only person to ever have a master's degree or any kind of licensure. And that's because I was given more opportunity to education, to access education than anyone else in my family. And I have higher income than anyone else in my family because of that access. So you see how it kind of goes on and on, right? So this is kind of like the intro to what we can do to create safer communities, right? And it's not an easy answer. It's not one thing that one person can do, but I think, especially in setting this foundation, right? Having more individuals, we're working every day to change the systems, right? We're working to change like these big overarching barriers, right? And I just want to encourage all of you to remember how powerful it can be to be a trauma responsive person. Yes, we're going to do the work to try to change some of the systems and create this like larger impact. And on the day to day, you being trauma responsive, you treating people in the ways that we know are trauma responsive and healing and helpful is going to change the dynamic. So this is going to be from a community perspective, like the big overarching thing, what we're trying to create ultimately. And I want to remind you that starts with you. That starts with you as an individual, as a human, as a parent, as a provider. And it goes out from there. So keeping that in mind, I don't want you to underestimate. I think sometimes when we do this work, and I don't know where all of you are in this, but I've been in this for a very long time. And sometimes it can be exhausting and overwhelming. And it can feel as if like we're not moving fast enough, right? It can feel like we're not doing enough. And I just want to remind you that every single conversation you have with a human, every single conversation you have, especially with a trauma survivor, every time you treat them with respect, every time you treat them in a trauma responsive way, every time you take the time to serve in a trauma responsive way, you are changing, and that ripple effect will happen whether you see it or not. Right. Susan, that's an interesting question. That's an interesting question for me. I'll share more about my own personal experience in like the trauma responsive care conversations, but I was always bought into the change. I never wanted it's not a conscious decision to have the behaviors that we might have. So I didn't need to buy into anything. I just needed to have someone who took the time to explain to me what was going on, to forgive me, right? To introduce me to the idea that it wasn't my fault. Like, so I'm just going to soapbox. Susan asked, okay? So I'm just going to do it. So for me, one of my biggest points of activation was my sexual abuse. And this is something that I think we all try to get survivors to understand, is that it's not their fault, right? And yet that was something I carried with me for a very long time. So it's something that I wouldn't talk about, I wouldn't share. And there's a whole background to that with my orientation as well. But after education, after support, after therapy my entire life, after having, like I said, counselors and teachers give me a chance, then I was able to realize like I'm carrying so much of what doesn't belong to me. Like I didn't abuse myself, right? So why am I shameful? Like I did some stupid stuff in high school, but I didn't like hurt anybody else or anything like that. And it wasn't a choice. The behaviors that I have, even to this day, let me show you something kind of funny. Okay. Right. It's not my fault. I didn't do any of these things to me. I'm just trying to make it through on the other side. Right. And I think when working with survivors, reminding them of that is incredibly powerful. Right. And I still have to be aware enough to know that I'm going to pay the price my entire life. It's not fair. It's not right. And yet I can't go back and change it. So like, I just have to deal with what I'm dealing with now, right? So a funny story about that really quickly is that to this day I still have a sensitive stress activation response, right? So I tend to be a dissociator, right? They thought I had epilepsy because I dissociate so bad. Well, now I'm in a safe environment. I'm in a healthy marriage. I like live this amazing, beautiful life. So it's the complete opposite of my childhood, and yet I still have symptoms. So one of the things that happens that I had to talk about with my wife when we first started dating is when I get stressed, I get sleepy. So even when I'm speaking, like I have to keep a piece of gum in the back of my mouth, or I'll sit here and yawn at you. It's I can't control it. My body just does it. I slept last night. I had coffee. Like it's just I get stressed. My brain wants to shut down. Okay? So my wife, when she comes to me and she's like, "Hey, we need to talk about something," immediately my brain goes to like, something's wrong. I've done something wrong. I'm in trouble. She's going to leave me. I don't know. My heart starts pounding. And so I'm like, okay, let's sit down. Let's talk about it. And as much as I want to be an active listener, I start yawning. So can you imagine going to your spouse and you're like, hey, honey, we need to talk about something very serious. And they're just yawning in your face. Like, you know what I mean? Like my poor wife. And how frustrating would that be? You know what I mean? And it's so like infuriating. She's like, I'm sorry, am I boring you? And I'm like, no, 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 no. Like, I'm so into this. Like, I want to hear what you have to say. I'm like taking notes because when I'm activated, I know I'm not going to remember things. Right. And so as soon as she says we have something serious, I know I'm going to leave. So I'm trying to like do my best. I'm taking notes. I'm like, hey, can I record this conversation? She's like, what are you, like, what is your, and I'm like, look, so I had to have a conversation about this is my situation, this is where I'm coming from, and this is how my body still expresses what it knows to do when I'm stressed. Like, so I love my body, I love my brain. They served me so well my entire life, right? They're why I'm here. So I'm not necessarily mad about it. And yet I still have to be like, look, this is going to happen. So we have to find a compromise, right? I have to take notes if we're going to have very serious conversations. I have to write everything down. If it's not on the calendar, it doesn't exist to me. We work together on that, right? And when we're going to sit down and have a conversation, I either need a piece of gum in my mouth or I need to be eating, right? I need to be keeping my oral self stimulated. I sit on a yoga ball when I'm doing trainings or class, when I'm on the computer for a long time, I sit on a yoga ball. So there's like all different types of things that I've had to learn to cope with my experiences. So it wasn't, I know that was a long-winded question and just I think like a funny story because my wife and I, she's so understanding and a survivor herself. We each have our own stuff, right? But it's important to have those conversations. And so for me, it wasn't a turning point necessarily, Susan, because no trauma survivor that I've known, to be honest with you, has said, I intentionally and meaningfully want to make these choices, right? Like I want to be an addict. I want to be violent. I want, right? It's something that happens beyond our consent. So I don't think it wasn't a turning point to buy into the change. It was an education of what was happening to me. And it was a huge leap into empowerment through my counseling, through my therapy, through my teachers and my coaches. I will say this, playing sports and working with my coaches really, really helped me in a big way because it made me feel capable. Now I lift weights, right? Now I'm a fitness trainer and I'm in the gym and I'm lifting heavy weights, and that helps me feel very capable. It's very empowering. And so it reminds me that although these are my symptoms and the symptoms themselves may be out of my control, there's a lot within my life that I do have control over and that I can choose or not choose. I can't choose to yawn or not, but I can choose to let people know that, and I can choose to try to find ways to cope with it. Does that make sense? And so I think that's the conversation. Exactly, Christina. It's just being honest with people, allowing people to be honest about their experiences and not shaming them for that and not guilting them for that and not, making it a choice, right? These are symptoms that happen to us. That's like being angry with someone for coughing, or having the hiccups, I think if we think about it in that similar way, it can help us to help them, right? So again, this is going to be from Safe Spaces. So it's going to have some information for you. It's going to have a link there for future trainings as well. But this is going to be the overarching what makes community safer, right? And then again, I just want to remind you that individuals are where that starts, right? Every conversation, every family, every individual, even for yourselves. Like I said, if you are a trauma survivor provider, all of this starts with you, and it starts with how you're caring for you. And that's a whole nother soapbox I can get on at another time, but I'll introduce you to this and then we can open it up for questions.
Hi, this is my neighborhood. I grew up in this building. This is a great community now, but it's had its share of problems. When I was a kid, our community had high unemployment, a lack of resources for families, and lots of kids hanging out with no adult supervision. You might have heard about Adverse Childhood Experiences, or ACEs. ACEs are traumatic events in childhood, like abuse and neglect, that can increase risk for future problems. But they don't have to. The good news is that ACEs and their consequences can be prevented. Take me, for example. I was at risk for ACEs, and despite all the things that put me at risk, some pretty incredible people helped make sure that I wouldn't become another statistic. Come on, I'll show you around. That's Jackson. He's a cool kid. His dad left when he was 2, and his mom works 2 jobs. I hang out with him every Thursday night and help him with his homework. Sometimes we grab ice cream. It's fun. Plus, he has another adult role model to learn from and trust. That's Mr. Martino. When I was a kid, he let me help him at the store sometimes after school when my parents were working late. He did that for a bunch of us. My dad actually found his job as a mechanic because of Mr. Martino. This helped our family in so many ways. Not only did my dad have a steady paycheck, which eased his stress about paying rent and buying necessities like food and clothes, but he was also a lot nicer to me, my brother, and my mom once he started working a job that made him feel good about himself. When communities come together, they can do so much to prevent ACEs. Mr. Martino and other local business owners put together a series of career workshops to help people like my dad find work. My mom also got a job with a company that allowed her to work from home and spend more time with me and my brother. Mariana has just gotten out of a class about handling challenges of single parenting. The clinic offers free childcare so Mariana's daughter, Ella, can play while Mariana's in class. The class helps parents like Mariana develop positive parenting skills, not just for babies and toddlers, but for teenagers too. This is another way our community has come together to give families the resources they need. And just one more way to prevent ACEs. This was my school, Riverside Middle, right in the heart of town. These kids are here for a sponsored summer camp. This community-supported program helps families with affordable, quality childcare and helps kids get tutoring and learn life skills. When I was a kid, I spent a lot of time at this school all year long. There was one counselor, Miss Greer, who I remember more than anyone. She was a really good listener. Miss Greer helped me and my brother get involved in after-school activities like baseball and soccer. Our coaches were super nice and were mentors to us. Staying after school for practice kept us and a lot of other kids out of trouble. When schools help take responsibility for preventing ACEs, everybody wins. My life could have gone in a completely different direction. Studies show that ACEs can have long-term negative effects on kids' health and well-being that may last into adulthood and even continue in future generations. But by people and groups taking action, ACEs can be prevented. In fact, there are 5 known strategies that help stop ACEs before they even start. You can implement them in your own community, just like we did. How? By strengthening economic support for families. By changing social norms to support parents in positive parenting. By providing quality care and education early in life. By enhancing parenting skills to promote healthy child development. And by intervening to lessen harms and prevent future risk. So, now you know my story, and you've seen the prevention strategies in my community that helped me beat the odds. I had healthy relationships with my family and friends. I learned how to take care of myself and make good choices. And today, I'm a mentor to other kids who need some extra help so they don't become an ACEs statistic. Safe, stable, and nurturing relationships and environments are essential to prevent child abuse and neglect and to assure that all kids reach their full potential. Are you thinking what I'm thinking? Banana split? You got it.
All right, and so there's a whole, the cdc.gov, if you just go to their website, you can find this prevention packet. It's just a whole PDF. And then the osg.gov also, www.cdc.gov. So both of these are going to have information on ACEs, a lot of prevention. Sorry, can't type and talk at the same time. All right, there you go. And a lot of other information for you, including this packet, this handout of what we can do to prevent, right? And also, so a lot of these things, like I said, are big picture kind of community-based things. So as individuals, what can we do? We can encourage these things. If you work within a department, you know, you can start, I know Juan's here, right? So we're engaging men and boys as allies, right? We're having parenting conversations. We're developing parenting skills. Like these are all the programs that you work in. So you're doing it. You're doing the work in all of these things. So my invitation is in whatever you are doing to just ensure that you're doing so in a trauma responsive way, in an inclusive way, in a safe way, and that's going to increase the impact, right? Mentoring programs are incredible. Whether they're, you know, the way I think about it is like whether your mentor is on your job description or not. If you have access to people, like some people working in a school, right? You're going to be a school counselor, I saw. Well, just because they're not on your caseload doesn't mean you're not mentoring every kid on that campus, right? So if you're doing so in a way that's trauma responsive and engaging, you're going to increase the positive outcomes for all of those young people, right? These are more handouts from the CDC. I just shared this with you. You can write to the CDC and get these printouts if you wanted to put them in your office or your classroom or what have you. If you wanted to print them out to hand them out to parents, if you're having a parent meeting, these are going to be like really quick, really easy infographics that the CDC has released. And they do a vital signs for ACEs every so often. So this will be updated as well. But I wanted to give you that as a resource. And before I open it up for questions, I do want to say this, which I say at the end of every one of my trainings, which is in any given day, in any given situation, we may or may not be the best person to help the individual in front of us, but I'm always going to ask that you first do no harm, meaning even if you don't necessarily know how to help the individual in front of you, I ask that you please do your best to not hurt them. Yeah. And then we try to get them to someone who can help. So with that, I want to say thank you so much. I'm going to open it up for questions, comments, concerns.